up. Yes, put it here. Yeah. Please come, ma'am. Welcome everybody to the very interesting session on keratoconus. It's called Battle of the Bulge. I'm very happy to have with us Dr. Prema Padmanabhan. She's one of the doyens in ophthalmology in India and a leader in the subject of keratoconus and refractive surgery. And it's really a privilege to have you with us, ma'am, today. She will also be delivering an oration at 11 o'clock in Hall A right after this session. Please don't miss it. That also will be on the subject of keratoconus, so it'll be a continuation of this. We have actually a very interesting array of speakers. Unfortunately, a couple of them have not been able to join, so we've had some substitutes, and Dr. Fogla will be joining via Zoom and show his recorded talk. So the flow of the session is we will be starting with diagnosis of keratoconus and a systematic overview of its management. Then there'll be a talk on collagen cross-linking, followed by role of excimer laser in keratoconus. And then there's a talk of stromal augmentation and use of intracorneal ring segments. And finally, the role of ectasia in keratoconus. I'll request Dr. Prema to just give her opening remarks, and then we'll have the first speaker, Dr. Vivek, who will talk to us about the overview of keratoconus diagnosis and management.
Thank you, Rishi. I think this is a very, today the options we have in treatment are just so many that it's important to understand how we make our decision tree and how we plan it. Rishi has put up a lovely program which covers most of the options that we popularly use these days. So I'm really looking forward to listening and hearing from you. Welcome.
Dr. Vivek Mahendra Singh is one of the young dynamic cornea surgeons at LV Prasad Eye Institute, and his areas of interest are keratoconus and refractive surgery. And let's see what he has to hear. He has made this on a very short notice because one of the speakers dropped out, and I really appreciate your putting in that effort for us. Thank you.
Thank you. At the outset, I would like to thank the organizing committee for giving this opportunity. Good morning all. What I'm going to talk about in the next 10 minutes is something about approach to management of a patient with a keratoconus. Keratoconus, now over the last few decades, the incidents have been increasing, and this probably can be because of the better diagnostic techniques or more awareness amongst both the doctors as well as the patients. Diagnosis of keratoconus primarily is based on your clinical history, clinical examination, and in early stages, a corneal topography. So what I'm going to show you here is a kind of systematic approach to a patient of keratoconus when a patient presents to the clinic. So these three things are kind of, forms the baseline of your keratoconus when the patients are present in the clinic. So treat your allergies and ensure that the patient does not rub the eyes and counsel them well. When you have a patient of a keratoconus, you try with the glasses first, and then you have your contact lens trial. Whatever vision is there, with these patients, and you can label them after getting a corneal topography done, so into a progressive as well as a non-progressive one. When you have a non-progressive keratoconus, and if the patients are younger, or the patients have hydrops in the other eye, or very severe keratoconus in the other eye, known patients of VKC or history of eye rubbing, you tend to cross-link them early. On the other hand, when you have a patient who are having lesser risk factors or who present a little later, usually you tend to a little observe them. And you send them for further contact lens trial or spectacle, depending on the need of the patient. On the other hand, when you have a progressive keratoconus, then there can be two options, whether the CXL is possible or the CXL may not be possible because of various other reasons. When the CXL is possible, you have two other options along with CXL you can plan either PRK or intracorneal ring segments, or you can plan CXL, wait for the stability for over a year, probably 6 months, 2 visits separated, and then probably you can treat or lower the cylinder of the patient, make them more comfortable with the contact lenses or spectacles with an ICL. Performing CXL alone in these cases can have two scenarios where you're performing CXL for patients who have a low pachymetry or patients who have adequate pachymetry. So when you have adequate pachymetry, you go ahead with your regular Dresden protocol, and when you have a lower pachymetry, choose the one with the hypoosmolar. There are other techniques which I think I would not be describing here. When you have a patient with, which are not suitable for CXL or have high drops, then there are two options when the vision may not be satisfactory or when the vision is improving with contact lenses. When the vision is satisfactory, you can either observe or there can be option of Bowman's layer transplantation as well. And when the vision is not satisfactory or has a lot of central scar, the option that would be left with you would be DALK or a PK. Okay, so let's discuss the indications of CXL in a keratoconus patients. Now, progressive keratoconus obviously is an indication. How do you decide for progression? When the keratometry value increases over 1 diopter over a period of year, or if there is decrease in the pachymetry, this is now changed to say 10% over a period of year, and when there is a change in cylindrical error as well. Are there any criteria when you, indications where you cross-link these patients in first visit? Yes, when you have an active allergy, like we discussed earlier, or patients who have high drops in the other eye, very young patients. Right now what we do, the practice that we have is we cross-link all the patients who present at age of 16 or lesser, and beyond that we tend to observe unless and until the patient has presented with very severe keratoconus. Another criteria for cross-linking these patients is inability to follow up later. Contact lens is a mainstay here, even before cross-linking or after cross-linking. If patients are presenting with very advanced keratoconus, we should get the contact lens trial prior to understand what is their best potential visual acuity that they can gain. And then once the cross-linking is done, 3 months later, we have to check for this contact lens fitting again. I'll be describing 3 interesting cases. So this is one where this 18-year-old female presented to us. This was in 2020, and she presented to us with diminution of vision in both the eyes, right eye more than left eye, with having a positive history in the family. This was her best corrected visual. She was improving to 2080 in the right eye with 3.5 diopter cylinder and 2050 with 3.25 cylinder in the left eye. She was diagnosed to have keratoconus in both the eyes. She had minimal allergy. We gave her medication. We advised her to come within 3-4 months, but she got lost to follow-up. And this was her vision at the end of 3 years. Yeah, so when we got the scans, these are difference map that you see at the end of, at the next visit. So how exactly do you see this map? So keratoconus in subsequent visit can progress. There can be steepening of the keratoconus, or there can be widening of the cone as well. So one common mistake that people make is they just look at the K1, K2, not realizing that the K1 and K2 are belonging to just the central 3 millimeter zone. The other mistake that is commonly done is looking at the Kmax. So there can be points on the cornea that can progress and that is not belonging to the Kmax. So it's always good to have or look at the global curvature map to look for the progression. Now in this map, you can see there is definitely a widening of the cone. So this is the first visit in 2020, and this is the visit when she presented in 2023. So as you can clearly make out, there is definitely widening of the cone as well as deepening of the cone, and point-to-point comparison is mentioned here. So anything more than 1 diopter over a period of a year is something considered significant, and we need to cross-link such eyes. This is the other eye of the same patient. You can see there's not much difference between the two visits. However, there is definitely widening of the cone. So this patient was diagnosed to have a progression at the end of 3 years and was cross-linked for both the eyes. Now this is a very interesting case. If you can note the vision for this patient, the refraction was not possible. The right eye, best corrected visual acuity or uncorrected visual acuity was the same. It was counting fingers 1 meter. Left eye improved to 20/20 with 3.5 diopter of cylinder. Now if you look at the scans here, this patient was advised collagen cross-linking elsewhere and reported to us. Now if you look at the keratometry, they're quite steep. And if you compare the values in the Kmax, it goes beyond 80. And you look at the pachymetry here, the thinnest pachymetry is about 447. So ideally, if such patient presents to you, you would go ahead and cross-link this eye, right? But then check the vision, check the keratometry values. The vision is counting fingers. A patient who is having a counting fingers vision and not improving, patient who is having a keratometry which is as steep as this may not have a pachymetry which is about 447. Do a good slit lamp examination here. In case you have a doubtful slit lamp examination, get an OCT done. This is the left eye, which was again having a keratoconus. Now this is the right eye OCT. What is interesting to see here is the pachymetry, which was shown to be 447, on slit lamp examination turns out to be very less. You can see in the area of maximum thinning is not even 200 microns. So you can see this area is actually the area which is epithelial hyperplasia. It's covering the defect, it's covering the thinning of the keratoconus here. So in this area, the thickness is just 313 microns. But the real stromal thickness would be even half of that. So this cornea is not amenable for collagen cross-linking. So this is another case where you can see there is, a very steep cornea. This has been already cross-linked, and that is why you can see the pachymetry is up to 366 microns. Over a period of year, if you can see the first scan, it is 2019, and the second scan, the comparative scan, is 2022. So 3 years later, we saw something which was, in the global curvature map, a lot of difference there. Would you label this as a progression, even after having a collagen cross-linking? Would this be a progression? So when you're comparing the subsequent maps, after a collagen cross-linking, be mindful that, your epithelium can remodel for a very long time. The usual time duration or remodeling, it takes about 1 year to 1.5 years. Now this is 3 years. But then it's always a good practice to get your epithelial mapping done. So when an epithelial mapping was done for this eye, you can see there's a lot of epithelial irregularity. So is that a frank progression? In case, in doubt, always treat the surface and observe another 6 months or 12 months to take this call when the patient has been cross-linked earlier. So this patient again was observed, and later on the surface was quite regular. So to summarize, any patient with collagen cross-linking, always control your VKC. A lot of surgeons across the world treat keratoconus by just controlling their allergy. Subsequently, very important, have a good counseling, talk to your patient, explain the course of or nature of the disease. Thank you.
Thank you, Dr. Vivek. I think you really covered some very important points. I'd like to just take this opportunity to ask Dr. Prema what she thinks should be the parameter, most important parameter we should decide on progression when we think about whether to cross-link a patient or not. And what are your thoughts on cross-linking primarily? Which are the patients we think we needn't wait for progression?
I would think as a standard rule to wait for progression before cross-linking any patient, including children. we have seen children with VKC who give a history of eye rubbing. When we counsel them and ensure that their atopy or their allergies are taken care of adequately by conservative treatment, and they are strictly asked not to rub their eyes, quite often the keratoconus does not progress. So you can avoid cross-linking in these children. Probably patients who are planning if they've had one eye getting worse with the history suggestive of worsening during pregnancy, and they're planning another pregnancy, that's when you have to be a little more watchful about the other eye and may have to treat that eye before preemptively. Your other question?
Yes, ma'am. Can we have a mic, please? You can take this.
Hello, ma'am. Hello, sir. Sir, I have a question. I get to see children, I mean not children, who are above 16 years, like they are around 17, 18. They come with 470, 460 Paki. But the problem is they have steep case. Like they have around 52, 59. And best corrected spectacle with spectacles, they come to around 612. So in such cases, do we have to still wait for progression? Because the steep case worsens further, even though the package is good. So should we wait for progression?
Yeah, so 17, 18 is a very tricky age. So what we follow at our center is like, if the patient is having an allergy and history of eye rubbing. So history plays a very important role here. The patient is complaining it has been gradual, progressive decrease in vision, then you go ahead and cross-link such eyes.
So these are the first cases, like
first
not
visit,
much
right?
of first visit, not much of an allergy, 17, 18-year-old with 612 vision. So should we jump and do C3 or should I wait for another 6 months to document it?
Yes, so if there is a history of progressive diminution of vision, you would want to save that 612 vision as well, right? Rather than that vision deteriorating further in the next 6 months. If the history suggests that this is a stationary one and there's no history of eye rubbing, there's no active allergy, you might just want to wait for some time and then document the progression and go ahead with CXL.
Okay, right, sir. Thank you.
We'll move on to the next talk in the interest of time. The next speaker is Dr. Sahitya Gogineni. She is a cornea specialist, cataract refractive surgeon at Best Vision Eye Hospital in Madhapur, and she's done her fellowship from L.V. Prasad Eye Institute. She's going to talk to us about an important topic. Ideally, we should have the cross-linking talk before this, but the speaker has gone to another hall. He'll be coming shortly. So she's talking about the use of lasers in keratoconus. Traditionally, we have been taught that we should not do any laser procedure in the cornea in keratoconus, but recently we have found that they do have a role, and she's going to tell us how we can use lasers to give better outcomes for our keratoconus patients in combination with cross-linking.
Hello everyone, good morning. Thank you, Dr. Rishi. So my talk is on different topographic treatments in case of keratoconus patients. Which patient is suitable for which type of ablations? So already Dr. Vivek gave a brief view on keratoconus, that it is a progressive asymmetric steepening with lot of fluctuating refractive errors. So patient usually, the main challenge here is patient has poor quality of vision with very high irregular astigmatism, and they poorly respond to spectacles. So if we directly go ahead and do the cross-linking, we can arrest the keratoconus, but the patient will not be happy with the quality of vision. So what we are targeting here is, we are stopping the keratoconus, we are actually making the patient to accept glasses, and we are increasing their quality of vision by doing different topographic treatments. Here mainly we concentrate on regularizing the shape of the cornea. so that the glasses acceptance will increase. And their visual acuity will be increased by reducing the aberrations. So I'll be discussing the 3 case scenarios. In the first case, the patient is having uncorrected visual acuity of 6/18 in right eye, with best corrected visual acuity of 6/9, with glasses minus 1.25 spherical and 1 cylinder at 50 degrees. Here when you see the topography map, patient having thickness of 481. So mainly in doing the topographic ablations, first thing I consider the corneal thickness. If patient is having above 450 microns, I go and correct with the their refractive correction I do. If the patient is having thickness of below 450, then I mainly concentrate on the corneal aberrations rather than the refractive correction. So again, the KVB value is showing 62, that means the posterior cone is elevated. In Schwind MRIs, we have an facility of checking each aberration. These are the aberrative values of the patient having coma of 1.26. So here when I go back and check the cylinder, it was 1 diopter and the coma was 1.26. That means more coma is actually, we can consider it as cylinder, not like completely, but we can measure according to the cylinder. So if I go ahead and do the correction of 1 diopter for this patient, anyway, in this planning map, I had incorporated the corneal wavefront mode. We have 3 modes in the CERUS scan. One is aberration-free, corneal wavefront guided. So I had chosen the corneal wavefront guided. Here you can see I had taken the corneal wavefront guided mode, and machine automatically calculates the aberration values. That means machine corrects the corneal aberrations automatically. Here the coma was 1.48, it's getting corrected. So if again I incorporate cylinder of 1 diopter, patient may land up with hyperope shifts, right? So I am correcting only 0.5 cylinder with the same acceptance, manifest refraction, and automatically machine calculates the aberration. So I'm correcting all these values. I'm regularizing the shape of the cornea. When I checked all the values, the spherical aberration value is minus 0.41, which is like negligible. So usually for keratoconus patients, I don't correct spherical aberration values because Dr. Rohit Shetty says usually that when we correct the spherical aberration values in keratoconus patients, their visual clarity won't be good. So I can negotiate, I can remove the spherical aberration values. I can correct only the limited higher order aberrations like coma, trefoil, astigmatism. I can concentrate only on those astigmatic values, aberrated values. Here these are the total scan. I am correcting 0.5 spherical, 0.5 cylinder for this patient with maximum ablation of 64 diopters. Again in this, if we check the epithelium was, I do epithelial mapping for every patient. Then I incorporate the epithelial value. So total here we are correcting 64 microns, 55 microns is epithelium, and the rest of the stroma is just 15 microns I am negotiating. So mainly I concentrate of removing only 20 to 30 microns. I don't remove more than that in a keratoconus patient. This is the second case. So in the first case, I had corrected the refractive error. This is second case where I had corrected only the corneal aberrations. So patient is having a refractive error of -6 spherical and -3.5 cylinder with 618, best corrected visual acuity. And here again, when you check, the thickness was 390. So I don't want to correct the refractive error where I need to preserve the tissue. That is my main goal. Here, these are the, again, the aberrated values, corneal aberrations of this patient of 1.33. The astigmatism was 3.75. So if I correct the corneal aberrations, the coma was almost 2.78. When we go back and check the cylinder power of this patient, it was 3.5. That means machine automatically it is correcting the 2.78 of coma. That means it is correcting the cylinder value, right? So for me, no need to incorporate more cylinder. So I had kept the 0 power, 0 spherical and 0 cylinder of this patient. Anyway, machine is going to correct the aberrations. Sorry. So based on the corneal thickness also, we can judge which patient, which way we need to correct. So this is post-operative 6 months. Patient is happy with 6.9 best corrected visual acuity. This is a short video how we plan in a keratoconus patient. So this is a serous topography where we check the aberrations first. And then there are, and here we have AF and corneal wavefront mode. I choose the corneal wavefront mode. In case of PRK, I select the AF mode, aberration free mode. So here I incorporate all the refractive values and I select the trans PRK. We have an option of choosing the optical zone according to the pupillary size. So I am reducing the optical zone because I want to preserve more tissue in keratoconus patients. Here I wanted to show one more thing, how I will deal with the aberrated. We have an option of manager where we can correct only limited aberrations in this machine. So when you see here, there is an option called minimize depth. That means machine automatically takes what is the exact refraction that is going to be corrected in case of keratoconus patient. Machine has a value. We can actually change that value. So we also has an option of pyramid, that means Jernick polynomials. The red color shows the higher degree of aberrations that are contributing to vision loss. The gray zones I had removed now. Those aberrations I don't want to correct so that I can preserve more tissue. Again, I am reducing the depth. We have all these options in Schwind MRIs. This is the final thing of what I am going to correct, what are all the aberrations I am correcting, the power what I am correcting. So we can see and then we can go ahead with the laser treatment. So these are two case scenarios. Always we check the major contributing aberration for the vision loss. That one we need to calculate, that one we need to check and incorporate in the patient profile, ablation profile. Apart from the thickness, I also choose what is the residual amount I am going to leave. Like usually I concentrate, my residual thickness will be not less than 350. So this is another case scenario where I do topography based removal of corneal epithelium in case of very severe keratoconus and moderate to severe keratoconus and patients having very higher order aberrations like glare and halos. Here the thinnest Paki will be less than 450. So more than 450 I deal with the refractive correction, less than 450 I do trek. So I wanted to show you how I plan trek. Here initially I ablate only the cone area. So I calculate from LO to LO, only the limited amount, like not more than 4 to 5 millimeter. So it will be always less than 4.5 millimeter. So I concentrate only the cone area. I ablate only in the cone area and the amount of ablation will be not more than 20 microns. So in total it will be 70 microns, 50 microns epithelium and 20 microns the stroma. This is how I calculate I do trek. So the tangential map I take first. These are the aberrated values. Coma trefoil I check how much it is and then I take the tangential curvature map. So here I calculate the vertical and the horizontal axis. And now I am calculate the horizontal axis. I measure how much mm it is and I center the cone. I take the centration of the cone. I incorporate these values here. First I am taking the patient's data and then I make it as 70 here, 60 based on the thickness left, and here the vertical mm and the horizontal mm I incorporated in the machine, and the offset. So what is the centration? So I take centration also with the degrees. Again, this is the area where I am doing the ablation. We can see clearly while we are ablating. This is another patient where I had done trek. The patient is having 414 thickness, that means less than 450, and the coma is 1.88 here. You can see the cone is inferior, centro-inferior. Then this is the planning I had done. This is the I had taken, 4.49 long axis and 4 short axis, vertical and the horizontal. 75 microns I had ablated in this patient. That means 50 microns, 55 microns epithelium and 15 microns stroma. So not more than 20 microns. So post-operative, after 3 months, this is the result. The coma has reduced to 0.86 and patient was happy with accepting glasses 6.6. Patient has gone into hyperop like plus 0.75 and minus 1.25 cylinder, but he was happy accepting glasses. This is what I wanted to concentrate. When we do topographic ablations, patient will accept glasses, their visual acuity will improve rather than directly doing the C3R. This is my protocol. Usually based on JS calculator, residual thickness, whatever is left, based on it, I reduce the time of UV exposure. My post-operative regimen is I give prednisolone 4 times per day for 3 days and after that I shift to fluoromethalone, tapering doses monthly. And additionally I give vitamin D for every patient and vitamin C. So in view of time, this is my study I had done in 51 eyes where and I had done 6 months follow-up. The visual acuity has improved, the K values and corneal thickness, the coma values are decreased and total higher order aberrations are also reduced. So topographic PRK along with the C3R showed visual, topographic and aberrometric improvement. It's a better improvement. The main advantage of tackling biomechanical stability and irregular astigmatism in one setting, we are doing both the procedures. It reduces aberrations, mostly coma, and it improves the patient quality of life and vision. Thank you.
Thank you very much.
Ma'am.
Do you have any questions for her? Any questions for Dr. Saithya?
Yeah, definitely I had seen more haze because here we are ablating the Bowman's layer and then we are doing C3R rather than only the epithelial. I had seen, but at the same time, the haze was reduced in 6 months, 6 to 7 months. So I follow them every month. I step up and reduce the steroids based on the haze. And after a year, the patient, all of them are mostly happy. But one patient actually gone into hyperop shift because I had overcorrected the patient. That's what I was saying. So that's the thing.
Thank you. If there are no other questions, I invite Dr. Arjun to speak about collagen cross-linking, when and how.
Very good morning to one and all. At the outset, I would like to thank Dr. Rishi and TOS for inviting me for this talk. And it's an honor to talk in front of Dr. Prema Madam. So I will be today presenting on collagen cross-linking for keratoconus, when and how. So as we all know that keratoconus is one of the commonest ectatic disorder in the cornea. So, and in most of the patients, especially in the younger patients, it is known to be progressive. So the reason for progression can be because of allergy, active inflammation, or eye rubbing. So we don't know whether which patient progresses and which patient it doesn't progress. So one history which we have to ask the patients is active eye rubbing is there or not. And there are treatment modalities for keratoconus include glasses, contact lens in the form of rigid gas permeable lenses, or in the last stages, we have to do a corneal transplant in the form of PK or DALK. So the role of cross-linking in keratoconus is only to halt the progression. So one thing which we have to counsel the patients is that cross-linking is only for halting the progression. It doesn't improve the visual acuity. So most of the patients after the procedure, they ask that the vision is not improved. So there may be an improvement in one line of the vision because of a little bit of flattening which can happen. But the patients have to be counseled that they have to wear either glasses or contact lens even after the cross-linking. And the idea of doing cross-linking is the keratoconus will be stabilized and it will not progress to a stage where the patient requires a corneal transplant. And as we all know that the corneal transplant has its own complications and high maintenance for the patients. They have to use long-term steroids, there is a risk of rejection, and to avoid that, cross-linking is indicated. So the goal of this presentation is what is the basic principle of cross-linking, how does it work, indications and contraindications, what are the variations of cross-linking which we do for a thinner corneas, and what is the evidence which shows that the outcomes of this cross-linking. So the basic principle of cross-linking is to halt the progression of corneal ectasia. Here what we use is UVA radiation along with riboflavin. So the basic concept is when riboflavin which is exposed to UVA radiation, so there is a photochemical reaction which is a form of photopolymerization and which in turn liberates free oxygen radicals. So these free oxygen radicals helps in the formation of intercollagen bonding, and this increases the corneal rigidity. So the basic pathogenesis of keratoconus is the collagen, the bonds between the collagen, the intercollagen bonds weaken, and that results in the ectasia. And also there is a reduction in the thickness of the collagen, and also there is a spacing between the collagen fibers reduces. So this cross-linking helps to increase the thickness by increasing the bonds. Here in this photograph you can see that before cross-linking there are less number of bridges between the collagen fibers, and after cross-linking there is an increase in number of bonds between the collagen fibers. So that's how the cornea becomes more stiffer and more rigid, and it doesn't allow the progression. So as Vivek described in his first talk, what are the indications for cross-linking? So there should be a documented progression. So whenever we see a patient on serial visits, at least in 6 months, there should be a change in best corrected and uncorrected visual acuity. There should be an increase in the refractive astigmatism, and there should be, in the topographic parameters, we have to see whether there is an increase in Kmax by 1 diopter, at least in 1 year, and there is a change in astigmatism or myopic shift greater than 3 diopters within 6 months. And the central corneal thickness has to be, if it is reduced less than 2% to 5% in 6 months interval, then that is described as a progression. However, in few cases, we need not wait for the progression to happen. For example, a young child who is at 10 years or 12 years of age, where you expect the progression to happen quickly, or the patient is active eye rubber, or there is active inflammation in the form of VKC, and the other eye, which suppose the other eye has landed in eye drops, then in those cases there is no need to wait for a progression. You can straight away do a cross-linking. So the contraindication for cross-linking is the first described procedure of cross-linking, which is called the Dresden's protocol, which is the standardized procedure. There the limitation for the cross-linking is the corneal thickness has to be more than 400 microns. So if it is less than that, cross-linking is not indicated. And any previous herpetic scar or a small scar with a deep or superficial vascularization, these cases we have to avoid a cross-linking because there can be reactivation of virus. And severe scarring and opacification, and there is a history of poor epithelial wound healing in the like dry eye, chronic dry eye, rheumatoid arthritis patients, we have to be a little careful. Also, pregnancy and lactation is a contraindication to perform a cross-linking. So the procedure is the procedure is done in aseptic conditions in the operating room, and under topical anesthesia. Once the anesthetic drop is put on the patient's eye, so the epithelium is scraped off with a 50-number blade. The size of the epithelial debridement is around 7 to 8 millimeters. And 0.1% of riboflavin solution with 20% of dextran is put on the patient's de-epithelialized stroma for 30 minutes in an interval of every 2 minutes. And later on, UVA radiation is put on the patient's eye, which is already soaked with riboflavin, and but that is done for 30 minutes. So the UVA radiation parameters are 370 nanometers, and the total energy which is delivered is 3 milliwatts per centimeter square, or 5.4 joules per centimeter square. So this is an ideal cross-linking procedure which was initially described, and there are various modifications in this procedure which I'll be describing in the next slides. So what are the complications which you can expect in after the cross-linking is there can be a treatment failure. So the literature shows that cross-linking works at least in 80 to 85% of the patients. So 10 to 15% of the patients, in spite of cross-linking, it can progress. So that is determined, that is called as a treatment failure. There can be a corneal haze in the immediate or late post-op period, which can reduce in the best-corrected visual acuity. And there can be a post-operative epithelial problems which can result in microbial keratitis. In very severe cases, there can be persistent epithelial defect or corneal melting. And in very severe, like if it is not done properly, then it can also result in endothelial failure, which can result in persistent corneal edema, or even in some cases, cataract is also reported. So these are the various studies which shows that standard cross-linking procedure, which was introduced way back, all the prospective and retrospective studies have shown that there is a stabilization of progression, and there is a little bit of flattening in the corneal keratometry, and that in turn improves the best corrected and uncorrected visual acuity. So this is a clinical photograph of the patient taken after 1 month of cross-linking. You can see that there's a little bit of haze which can be seen in the central part of the cornea, and this is on the slit section. You can see a demarcation line, which is an indication that the stroma has been cross-linked, and that is seen at the level of at least half of the corneal thickness. You can see that there's a little, on ASOCT that is confirmed, you can see a hyperreflective layer which is seen in the middle of the corneal layers. That is nothing but a demarcation line which shows that the cornea has been adequately cross-linked. And another thing is most of the patients complain that there's a little bit of drop in visual acuity in the immediate post-op, 1 week, 1 month, or 2-3 months. That is because of the little bit of haze which is there. So we have to counsel the patient that it's a good sign. So that means the cross-linking is working in your eye, and this demarcation line will gradually fade off within a period of time. So the described procedure which was initially described, the standard C3R procedure, was done in corneas where the thickness was at least 400 microns. But most of the patients, if they come in late stages where the corneal thickness is less than 400 microns, then there are other modifications which are different from the normal C3R, and that I will be describing now. So that includes epithelium on or transepithelial cross-linking, accelerated cross-linking, hypoosmolar cross-linking, or contact lens assisted cross-linking. So in accelerated cross-linking, the concept depends on the reciprocative law, where the deeper penetration in riboflavin and UVA toxicity, with accelerated cross-linking, there is deeper penetration of riboflavin and UVA, and there is a higher intensity and simultaneous reduction in the corneal exposure. So demarcation line is seen at around 100 to 150 microns depth, and this is suitable for corneas which are less than 400 microns. So here what we do is, so after debriding the epithelium, the riboflavin is put for 30 minutes, and like the standard procedure, but the radiation is put only for 5 to 10 minutes. So the operating time reduces. So this is more patient friendly, and it can be done in children who don't cooperate for 1 hour procedure, and this reduces the patient discomfort, and the results of accelerated cross-linking are as good as and almost comparable to the conventional cross-linking, and there is no significant endothelial damage or any epithelial healing problems in patients who have undergone accelerated cross-linking. Other procedure which is described is a transepithelial cross-linking. Here benzalkonium chloride, EDTA, tetracaine, for example, have been used along with riboflavin, which helps in deeper penetration of riboflavin, and this Transepithelial cross-linking, here the epithelium is not debrided, so there is no risk of infection. It reduces the subepithelial haze and reduces the herpetic reactivation or endothelial damage. This is more comfortable for the patient, and but the problem with this procedure is it is not time tested, and there is more chances of treatment failure rather than this procedure being successful. Another procedure which is described is hypoosmolar cross-linking, where the basic concept is the de-epithelialized cornea can swell to double its normal thickness when irrigated with a hypoosmolar solution. So here 0.1% dextran-free hypoosmolar riboflavin is administered until the corneal thickness at the thinnest point reaches 400 microns. Then the UVA radiation is started. So here the minimum thickness to use hypoosmolar cross-linking is at least the cornea should be 330 microns. So again, the evidence shows that this procedure is not as successful as the conventional or accelerated cross-linking procedure. Another procedure which is described is a contact lens assisted cross-linking, where a contact lens is of roughly 90 microns thickness, is immersed in isoosmolar riboflavin 0.1% dextran for 30 minutes. Then this contact lens is put on a de-epithelialized corneal stroma, and which is already saturated with riboflavin, and the UVA radiation is put for 30 minutes. So the advantages of contact lens assisted cross-linking is that it doesn't depend on the selling properties of the cornea. There is less endothelial damage, but the irradiation is reduced by at least 50%. So there is more chances of treatment failure with contact lens assisted. Another procedure which is described is a custom epithelial debridement, which Sahitya has described, is used in patients where the corneal thickness is less than 400 microns. So 8 millimeters of corneal epithelium is debrided, leaving a small localized area of corneal epithelium corresponding to the thinnest area of the corneal apex. So in that area, the epithelium is not debrided, whereas the rest of the area, the epithelium is debrided. Then a cross-linking is done, but this is not very effective or comparable and like the routine ones, because the epithelium over the cone is spared and the stroma underneath the spared epithelium is not cross-linked. The newer modifications which is described by Professor Hafezi is sub 400 microns cross-linking, where it is customized according to the patient's corneal thickness. So here the energy, everything is the same, only the fluence settings are changed according to the patient's corneal thickness. So in conclusion, so the standard procedure or the residence protocol is time tested and it works well, along with accelerated cross-linking also works well, whereas other procedures, it is not proven, and they can be tried, but there's no guarantee or surety that this works and it halts the progression.
Is the Zoom ready? Thank you, Arjun. That was a very comprehensive talk on cross-linking, and I'm sure everybody understood a little more than they knew previously. Please come. Is the next talk ready? Yeah, please start. The next speaker is Dr. Rajesh Fogla. Unfortunately, he's not been able to join us, so we're going to play his recorded talk, and then he will be available for any comments on Zoom. Is the Zoom live?
Good morning, everyone. I shall be talking about the role of Intacs and stromal augmentation in the management of corneal ectasia. Among the contact lens wear, intracorneal ring segments and stromal augmentation are definitely a useful option for these patients. Intracorneal ring segments come in various shapes and sizes. They're usually made of PMMA, varying arc length and thickness. They can be hexagonal, oval, or triangular in shape, and the segments can range from 90 degrees going all the way up to 325 degrees. The intracorneal rings work by additive procedures. They cause focal steepening, and the stretching of the cornea leads to a central flattening. The clinical appearance is something similar. On the OCT, you can see that they are usually placed at about 80% depth. They can be implanted using the femtosecond laser, where the channel is created in the cornea. You can do the same using manual instruments as well. However, the accuracy and the predictability of the depth of the pockets is far more accurate using the femtosecond laser. The ideal cases would be mild to moderate keratoconus, post-LASIK ectasia. The steep case should not exceed 58 to 60 diopters. The minimum corneal thickness of the site of implantation should be about 400 microns without any absence of corneal scarring. And the patient should have realistic expectations and should not treat Intacs as a refractive procedure. This is a nice paper published back in 2014, which gives you the information regarding the surgical planning. So it's basically based on the location of the cone, the superior inferior asymmetry, and the spherical equivalent, and the mean K that you're dealing with. These are some of the cases which I've operated over the years. You can see that we have used both two segments and single segments as well. Now, if you have a inferiorly displaced cone and you don't have a very high refractive error, you can go ahead and place a single segment. Like in this case, we put in a Intacs SK segment of 400 micron thickness, and you can see that post-operatively the uncorrected visual acuity has improved to 6/18 and best corrected to 6/6 with reduction in astigmatism. But if you have a slightly larger cone, which is again slightly inferiorly displaced, but also has significant higher amount of spherical equivalent, then you can place asymmetric rings where the superior ring is slightly thinner and the inferior ring is thicker to achieve the desired outcome. Here you can see post-operatively the cone is much more central, and there is a good reduction in the astigmatism from almost 6 diopters going down to 2 diopters. There's a case of post-LASIK ectasia, unhappy patient, obviously, and astigmatism of about 4 diopters, improving to 6/9. And we did a Intacs SK implantation. The incision is always at the steep axis. 350 micron segment was chosen at 400 micron depth. And you can see post-operatively there's a good reduction in the asymmetry of the cornea, which basically you can see the inferior flattening. And the higher aberrations show you why the vision has improved. So there is a good reduction in the coma and the total higher aberrations. You can combine intracorneal rings with any of the other procedures like cross-linking, triple-guided PRK, or toric ICL implantation. Like in this case, we presented with mild to moderate keratoconus. We went ahead, we did you can see that pre-op there is significant amount of coma. We went ahead, did a single segment implantation using the femtosecond laser. And post-operatively, the visual acuity improved to almost 6/9. And you can see from the topography that the asymmetry is gone, the astigmatism looks much more regular. Now, at this point of time, we could have chosen one of the two options of either putting a toric ICL or doing a triple-guided PRK. That's the pre-op, the maps. And we went ahead, did a topo-guided PRK, treating only the astigmatism of about 4 diopters. This was done at least 3 months after the intracorneal ring implantation, stable topography. And from pre-post, you can see that his visual acuity improved to almost 6/6, 20/20. And you can see the post-op higher aberration map, there is almost a coma has been eliminated. So this is sometimes the ideal goal when you have a patient who's not improving and doesn't want to wear contact lenses. You can use a combination of procedures to achieve the goal. Long term, yes, you can have deposits along the intracorneal rings, which are not clinically significant. If you make larger pockets, the segments can migrate. And if you make the incisions in the vertical axis, and sometimes if the incisions are gaping, you can have epithelial plugs and you can have vascularization of the site of incision. And progressive thinning of the overlying stroma can result in extrusion of the implant. This is a patient 9 years after intracorneal ring implantation. He had early erosion. We asked him to remove the segment, but because of the good visual acuity, he didn't want to. Finally, he had a melt, for which we removed the segment, and we had to use a small corneal tissue to cover the defect. But post removal also, his effect of intact was still maintained, possibly because of the induced corneal scarring along the channel, and he still maintained his visual acuity of 6.9. Stromal augmentation is a good option. We did that back in 2015, 2016. This is a 20-year-old female, did not want to wear contact lens, and we were not very keen on doing a corneal transplantation. So let's look at, so this was the pre-op map. You can see this fairly moderate keratoconus. So among the options that we considered, intracorneal rings was not a great option because of the advanced keratoconus. So we decided to do stromal augmentation based on the positive results from Bowman layer transplantation, and there were several reports of femtosecond laser-assisted intrastromal corneal lenticule. So we prepared the donor using the femtosecond laser, 8 millimeter in diameter, 100 microns in thickness. And this was done from the surface, so included the Bowman's layer. And we thought that maybe if we cross-link it, we can make the lenticule stiffer and maybe reduce the need for cross-linking later on. So we did the accelerated cross-linking after soaking the donor tissue in riboflavin, and this was just for 5 minutes. And for the surgical procedure, it was fairly simple, done under topical anesthesia. We created the pocket using the femtosecond laser, opened up the pocket, and took the lenticule, pretty much something like a DSEC lenticule. And then we pulled the lenticule into the pocket using a microforceps. And then by just gently manipulating using a 27-gauge cannula, the stromal lenticule could be opened up. We could have marked the surface to ensure that the Bowman's layer is on top. I'm not very sure whether the orientation would have made any specific impact on the final outcome. And this is how it looked immediate post-operatively, and that's the change. You can see that now it's beginning to look like more regular astigmatism, although the cylindrical power has increased from 7 diopters to 11 diopters, but it's still looking a little bit more regular, and the patient visual acuity, best corrected visual acuity did improve. And that's the anterior segment OCT, showing you the 100 micron thickness lenticule placed at 200 micron step. And 6 months later, we decided to do a topo-guided PRK, since now the corneal thickness had increased. And along with that, we also combined it with accelerated cross-linking. And that's how the patient looked post-operatively. You can see that the cornea is fairly clear, that's in cross-section, and pre and post the topo-guided PRK. And that's how the patient's topography looked post-operatively. Astigmatism is down from 11 diopters to 5 diopters. And you can see that the thickness of the cornea is again looking more like a normal cornea. And that's the transition from pre-op to post-lenticule and post-topo-guided PRK. And the patient's wavefront maps, if you see, you can see a significant amount of coma pre-op. This is post-lenticule, and this is post-topo-guided PRK. And the patient visual acuity improved quite a bit. This is another patient, again with moderate keratoconus, where lenticule implantation was done and where PRK was followed up. That's the change in the difference map, and that's how the patient looks 5 years later, still maintaining a stable refraction and a best corrected visual acuity of 6/6. We published our results, presented our results at the ESCRS in 2016 and the ASCRS in 2017. And that's the clinical data sheet. It's a busy slide, but if you compare the best corrected visual acuity pre-op, you can see that all ranges between 636 to almost 618. And if you look at the post-op best corrected spectacle visual acuity, it ranges between 618 to 66. And the subset of patients that underwent topo-guided PRK, all of them had visual acuity of 6/9 or better. And that's basically pre-op, post-lenticule, and post-topo-guided PRK. Again, the best spectacle corrected visual acuity from 618 has improved to 6/9. The astigmatism has not reduced significantly, but it's become more regular. The coma shows a significant reduction. This is again another patient where the stromal lenticule was placed, and that's the change in just by implanting a shaped lenticule. So in this case, what we did was we took the lenticule and we did a 50 micron ablation in the center using the excimer laser from the stromal side, and this was implanted. And you can see that it's made the cone more central, and the astigmatism is down to just one diopter. And that's pre and post difference map. The advantage of doing a stromal augmentation using donor lenticule is that it's pretty simple using the femtosecond laser. It increases the corneal thickness without any negative impact on the visual acuity. The clarity of the cornea is maintained, and because of the increase in thickness, you can perform a topo-guided PRK, and which improves both the unaided and the best spectacle corrected visual acuity. And in the follow-up that we have not seen any evidence of progression. This is a nice review paper which looks at the laser-assisted stromal keratophakia. You can see that there are various shapes that have been published, a donut or a concave or a convex-shaped lenticule. The conclusion of this review was that the lenticule implantation basically expands the stromal volume of thin corneas. It flattens the central cone and significantly improves the visual acuity. Looking at another interesting technique of implantation of allogenic intrastromal ring implantation, also called as SCAIRS. Various techniques, and recently people have started implanting it after dehydrating the cornea to make it easier to implant. I have an experience of doing about 6 eyes, and you can see that's one of the patients post-operatively where instead of putting a PMMA ring, we have used stromal lenticule implantation. That's the pre and post. You can see a significant reduction in the asymmetry of the cornea. The corneal steep K has also reduced quite a bit. The astigmatism from 6 diopters is down to about 0.5. And that's the difference map, again showing you the significant amount of flattening by implanting this stromal segment. This was about a 350 micron segment implanted at 200 microns depth. The inner and outer diameter of the rings were 5 and 6 millimeters. So additive procedures such as intracorneal ring segments or stromal augmentation techniques have a definite role in the management of corneal ectasia. The use of femtosecond laser and maybe intraop OCT will allow easier insertion and greater customization of this procedure. In the future, integrated with real-time assessment of intracorneal shape analysis and refraction, I think that will help us further customize these procedures, and they will play an important role in the management of corneal ectasia, and thus obviate the need of corneal transplantation surgery. Thank you. Thank you for your patience here.
Any questions from the audience?
Sir, is there any age limit for all these procedures, sir? At what age these procedures can be done, sir?
Cross-linking usually, as I said, progression usually stops after 30 years of age. 30. So there's no need to do any cross-linking after 30 years, but rare cases can progress even after that. So in those cases, it can be done. But all these procedures like topo-guided PRK or Intacs, I don't think there's any age limit. So we can do it at any age.
Topo-guided treatments usually...
Children who are developing, increasing every year the astigmatism is growing. So are they not suitable for this cross-linking?
We can do cross-linking along with the topo-guided treatments in case of children also, but it mainly depends upon the corneal thickness rather than the age. Usually children we have to do straight away, but we can check in 6 months follow-up if the astigmatism was increasing, of the cornea steepening is increasing, we should straight away go and do the cross-linking. Doing combined treatments is our option. If they had more irregularity in the cornea, we can do combined treatments, but if patient is having very early keratoconus, we can do plain C3R rather than doing the combined treatments. So we close the session and move on to the oration.
We'll all move to Hall A, where there's an oration going on. Thank you everyone for your patient hearing.
watching.